Today we're going to talk about traumatic brain injury. That, by definition, TBI refers to a type of brain dysfunction resulting from trauma that may or may not result in permanent damages to the brain, and it may cause some structural injury to the brain. Just some statistics about how prevalent it is. Um, 1.7 million people in the US annually are affected by traumatic brain injury, and it contributes to about a third of trauma-related death in the country. Luckily, most types of TBIs are mild TBI, and they do not have serious consequences. And majority of cases of TBIs are in either children or elderly. Let's just review the anatomy of the head, see what we have in there. We have all the way on the top, we have the scalp, the scalp. See my mouse moving or no? Then we have the skull. Then we have the brain. The brain has three parts. It has the cerebrum, cerebellum, and brainstem. Then we have ventricular system, dura, and tentorium. Let's go through these one by one. So the top layer on the head is the scalp, which is mostly consisted of soft tissue and blood vessels. The scalp is very rich in blood vessels. Why is this important to know? Patients can bleed a lot from a simple scalp laceration. So you have an elderly person who passed out, maybe syncopized, maybe fell, and now she has a laceration to her scalp. And of course, you're concerned because this patient is elderly and you want to make sure she doesn't have brain injury. You take the patient to CAT scan, to this way, X-ray, you're doing blood test, and you ignore that laceration for an hour or two. That person can bleed from that laceration significant amount of blood, and it can cause serious injuries, right? So one of the things that we do when somebody has a scalp laceration, very quickly, you need to control the bleeding, maybe a few staples, maybe a few sutures, or maybe just compression dressing to make sure the the they don't bleed a lot while we are doing the diagnostic workup, right? So keep in mind the scalp is very rich in blood vessels, and people can bleed a lot from a simple scalp laceration, which is very common in head injuries. Then you have the skull. The skull protects the brain. It's consisted of 8 bones: temporal bone, occipital bone, parietal bone, sphenoid, frontal, and ethmoid. The the front and back bones, the frontal bones and occipital bones, are probably the strongest bones in the skull. Why is this important? If you have someone who has frontal bone fracture, that means the amount of force that that the skull has received is very significant, and there's very likely that you have brain injury because the force that has to be transmitted to the skull to break the frontal bone, that means you most likely have serious injuries inside the skull. So um, take the frontal bone and occipital bone fractures very seriously. The most common bone that's broken, which is probably the thinnest outside layer, is the temporal bone. Then you have the cerebrum. Cerebrum is consisted of gray matter and white matter. And then you have two types of folds: brain folds, when the brain folds on itself, and you have gyrus and sulcus. Sulcus is the deep folds, and gyrus are superficial folds. Brainstem. I'm sure you've gone through the head and neck anatomy, so we won't spend too much time here. But brainstem controls some of the most basic body functions, such as breathing and arousal. And then you have cerebellum, which controls uh, balance and sits all the way down in the occipital bone area. Tentorium provides support for the brain, so brain doesn't bounce up and down or front or back. You have two. Tentorium has two parts. One part separates the occipital bone from occipital lobe from temporal lobe, and one part cerebellum from cerebrum. Again, the function of the tentorium is to prevent the brain from bouncing around. Then we have the ventricles. That's where the fluid, the cerebrospinal fluid, flows. The function of the fluid in there is to provide cushion for the brain, so it keep it buoyant, and it's a space with the least pressure in the head, and you can frequently have bleeding inside the ventricle if there's an injury. Knowing the different layers of meninges is very important, and you will see how the anatomy of the meninges impact the type of injuries that brain has. The top layer, so this is the skull, and you're looking at under the skull, between the skull and the brain. Meninges have three layers. The top layer is dura mater, which is kind of stuck to the skull. There's not much space in there. Then the second layer is arachnoid, which is loosely sitting in the middle, and then the lower space, the lower layer is pia mater, which is stuck to the brain. So you have dura mater on top, stuck to the skull, pia mater stuck to the um, brain, and then you have arachnoid layer in the middle. There are a lot of veins in the under the arachnoid area. We have a lot of vasculature, which we'll learn why they're important. All right, so moving on from the anatomy, there are different types of traumatic brain injury. Most common one still is falls, MVAs, um, struck by or against uh, something, and assaults. Where I am from Brooklyn, this is the 99.9% of the, oh no, these two, mostly assaults. Uh, there are different types of mechanism for traumatic brain injury. One type is penetrating versus blunt. Again, it's self-explanatory. You can also divide the TBI into focal versus diffuse traumatic brain injury, and then we'll talk about primary versus secondary injury to the brain. The penetrating is obvious. A sharp object penetrates through the skull, damages the brain. That's penetrating TBI. Blunt is when you have brain injury, but you don't have nothing penetrates the brain, and that's assault, bicycle crash, motorcycle crash, falls, and MVCs. Now, the other the type of TBIs, you can divide them into focal brain injury versus diffuse brain injury. Focal brain injury, self-explanatory, just this one part of the brain is affected. As you can see, we have different types of focal brain injury. We have contusion, epidural hematoma, subdural hematoma, and intraparenchymal hematoma. So this is a This is an epidural hematoma, this is an intraparenchymal hematoma, and this is a subdural hematoma. Diffuse brain injury is a type of severe TBI that the entire brain or majority of the brain is affected. You're going to have hematoma, edema. The entire brain usually causes significant sequela in the brain, or sequela in brain function and has serious consequences. But it's a type of injury that affects the entire brain. This is a CAT scan of subdural hematoma. As I said, uh, under the dura, there are lots of bridging veins, lots of vasculature, bridging veins. In the elderly, when the brain shrinks, that space, the subdural space becomes bigger. And these bridging veins are kind of hanging in that space. And a sudden shake of the brain when somebody falls or has a acceleration, deceleration in a car accident, those bridging veins rip, they tear, and then bleeding occurs in that space. And it gives you this kind of crescent shape, concave shape, um, subdural hematoma. So subdural hematoma mostly happens in elderly people when the brain is shrunk and the bridging veins are kind of hanging in the subdural space, and any sudden shaking can rip the veins and cause subdural hematoma. Epidural hematoma happens in that space, that tight. Remember, I told you the dura is stuck to the skull, so it's a very tight space, but you have a lot of arteries in there, and it requires more force. When that force happens, the artery is damaged. The arterial bleed kind of pushes the dura down, and then you have this kind of concave formation of blood that's called epidural hematoma. So epidural hematoma most of the time is arterial bleed and can accumulate, can become bigger very, very fast. Subdural is usually from veins and causes that crescent shape hematoma. And then you have contusion, which basically means a small part of brain is crushed. It's focal, local area of damage to the brain, and you can see it here on CAT scan. Usually, there's bleeding, crushed brain, looks white on CAT scan, and you can see it on autopsy. There's a hematoma in there. So, penetrating versus blunt, focal versus diffuse, right? And now we want to talk about primary insult versus secondary insult. Primary insult is when that immediate injury to the brain. That's a primary insult to the brain. That immediate injury could be tearing, crushing, whatever injury happens to that part of brain. That's the primary insult. That's the primary impact of the force or energy that causes the injury. That's one thing, and it is based on which part of the brain it is. It affects that the function of that part of the brain, right? It can affect the speech, it can affect um, cognition, or it depends where the insult is. So that's the immediate impact, immediate damage to the brain. But unfortunately, the majority of the injury to the brain happens secondarily, happens afterward. And those are the factors such as inflammation, damage to the blood-brain barrier, swelling of the brain. The secondary injuries are most of the time worse than the the primary injury. So we have primary insult and secondary insult. Most of the time, you don't have to do much for the primary insult because it's a part of the brain that's damaged. It's either going to recover or it's not going to recover. But most of your job is to prevent the secondary injury to avoid added insult to the brain. So secondary insult could be from inadequate perfusion to the brain, could be hypoxia. We talked about this yesterday. Biochemical changes, and brain swelling. This is the CAT scan similar to what I showed you yesterday. You see the brain is swollen and you have petechias everywhere. And on the CAT scan, you see all the gyruses and sulci are all gone, and you can see the swelling of the brain from a secondary insult. Any questions so far? Cerebral blood flow is very unique, and I think the word that I used yesterday, finicky, which means very sensitive. The cerebral blood flow has a unique quality, which is autoregulation. The cerebral blood flow can control the blood flow to the brain based on how high or how low the blood pressure is. If the blood pressure is too high, if the systemic blood pressure is too high, cerebral blood flow, the arteries in the brain, they can constrict and prevent, reduce the pressure in the brain. If the systemic blood pressure is low, the blood vessels in the brain dilate to allow more blood to flow into the brain. So the autoregulation is extremely important for survival of the brain. And when autoregulation is compromised, that's where the intracranial pressure can go up or can go down, and basically the brain uh, damage is more brain damage is going to occur. So autoregulation of the cerebral blood flow is key in managing the intracranial pressure. This is just a flow diagram that as the volume in the brain goes up, the pressure significantly peaks. Why would the volume in the brain go up? From swelling, from hematoma, right? Any of those can increase the volume of the brain. Remember, the skull has a limited space. Skull doesn't expand. It's a fixed space. So any amount of volume increase going to cause significant increase in intracranial pressure. In a normal scenario, 80% of the skull is brain, 10% is blood, and 10% is CSF. Any change in this formulation can cause significant increase in intracranial pressure and could damage the brain tissues. And what happens when the intracranial pressure goes up? What happens when you have too much volume, too much pressure? The brain has to find escape. It has to find somewhere to go and escape from the pressure. And this is a phenomenon called herniation. In If there is any opening in the skull, like in kids, we talked about that yesterday, sutures are open, or in adults who have previous craniotomies, the brain can push through that opening of the brain, or there are several areas in the brain that have less pressure and the brain can herniate through that. What happens when a part of brain herniates through a space? It becomes strangulated. When it becomes strangulated, that area, not only that part of the brain becomes ischemic, but the part that the brain is pushing on also can become ischemic and can be injured. So how do we manage secondary insult? So again, when primary insult has happened, the damage to that part of the brain is done. How do we limit the damage to that area, and how do we prevent the further injury to the brain? To the two key points are to prevent hypotension. Remember, if hypotension affects brain perfusion, cerebral blood flow, and we have to avoid it at all cost. The map has to be maintained over 80 millimeter mercury. And also we have to prevent hypoxia. Brain is extremely sensitive to oxygen, a lack of oxygen. And we have to make sure that the brain is not um, deprived of oxygen. One way to measure how severe the brain damage is by measuring Glasgow Coma Scale. The, the, this scale or this score is designed to see how eye-opening verbal response and movements uh, after the injury are, so to estimate the severity of injury to the brain. The GCS has three components. First component is eye opening. If the patient is able to open his or her eye spontaneously, they get a score of 4. Um, if they open their eyes with verbal command, so the eye is closed and you say, sir, ma'am, can you open your eyes, and they open their eyes, they get a 3. If you have to have them open their eyes with painful stimuli, they get a 2. And if the eyes are not open regardless of verbal command or painful stimuli, then they get a 1. For verbal response, if they're oriented to time, person, and place, they get a 5. If they appear confused, they're alert, they're awake, but they are confused, 4. Mumbling words gets a 3. Incomprehensible sounds gets 2, and no response gets 1. For motor response, um, obeys command 6, moves to localize pain 5, flexes or withdraws to pain 3, abnormal flexion gets 3, abnormal extension gets 2, and no response gets 1. So they usually add the GCS to 15, but in reality, when you tell someone the GCS is 9, it doesn't really mean anything. You have to break it down, and you say patient gets, let's say, 2 in eye opening, 3 in verbal response, and 5 in motor response. So you have to break down the elements of GCS and not just add it up. This GCS will come handy for you for the rest of your career. Memorize it. It applies to trauma mostly, but now more and more people are even using it in status epilepticus and in other causes of altered mental status. But it was primarily designed for trauma. So now, based on the severity of um, traumatic brain injury, we have 3 types of TBI. Mild TBI is usually uh, a loss of consciousness, LOC, but it's very brief. GCS is 15. Amnesia is less than 24 hours, and there are no radiological evidence of any brain injury. Moderate, you have more prolonged LOC, but it's still less than 24 hours. GCS has to be between 9 and 12, and there might be some radiological changes, but nothing severe. The severe traumatic brain injury, the prolonger LOC, GCS less than 9, prolonged amnesia, and you should have some evidence of uh, brain injury on CAT scan or MRI. So we will briefly talk about mild, moderate, and severe traumatic brain injury. As I mentioned, mild TBI is probably the most common cause of TBI. What it means is that the brain is shaken severely. This is also sometimes you hear concussion. Concussion is is the same as mild TBI. There are really no structural damage to the brain. It's just a sudden shock to the brain, but it can cause sometimes very debilitating symptoms. Initially people have headache, dizziness, lack of concentration, but there is an entity called post-concussion symptoms. Most people re, most people uh, most people's symptoms is resolved after a few days. Most people don't have any serious symptoms after the first few days. But some people, sometimes somewhere between 15 to 30% of patients will have uh, prolonged, sometimes weeks or months. Issues with the sleeping, issues with concentration, inability to sleep, that sometimes could be very debilitating, could be very annoying. So concussion is not necessarily as benign as we thought, because some of the long-lasting symptoms can really, really affect the patient's function. As I said, the initial signs are headache, dizziness, attention deficits, amnesia, um, sleep disturbances, but most people survive without any issues. It's important to obtain a really, really good a medical history, do a good exam. This is a mini mental exam that sometimes people do to identify presence of mild TBI. And of course, in sports medicine, the TBI has mild TBI has gained a lot of attention, because they have realized that while mild TBI or a concussion might not be a big deal, but continuous TBI, recurrent TBI, like American football players or some soccer players that have head injuries repeatedly after a long time, is actually can be a serious issue and should not be ignored. And uh, NFL actually a few years ago, I don't know if they're using it widespread or not. They designed certain sensors inside the helmets to measure severe force to the helmet, and for players that had those sensors showed that there has been multiple severe force to the helmet, they would test them for TBI or recurrent TBI. I don't know if they're still doing it or not, because in American football, every second something bang, there's always crashes and severe head injuries. And obviously, different areas of the brain have different functions, and depending on which area of the brain is hit or receive the initial impact, you'll have different symptoms. People who have frontal lobe concussion, they have problem-solving issues, emotional traits, uh, issues with reasoning, difficulty speaking, uh, voluntary motor activity. Again, these are the different functions of different parts of the brain that, depending on where the impact was, different functions could be affected. So the question for you when you work in the emergency department is, who do who needs a CAT scan? Who needs imaging? Obviously, you don't want to expose everyone to radiation, right? Not everyone who has a head trauma should get exposed to radiation, and you need to allocate your resources properly. We have a couple of different rules that all of them have been validated. It's Canadian rule. We have Canadian head CT rule, Nexus rule, and Pecan rule with Pecan rule, but that is for children. You can use these rules to determine who needs a CAT scan. And usually um, one of the major elements of these rules is mechanism of injury. So how if the mechanism of injury is serious, you might have to consider a CT. So let's say you do a CT and the CT scan is negative. Doesn't mean this patient is safe to go or not. You have to consider the risk factors, like in elderly who have a TBI, mild TBI, if they are taking any anticoagulation for AFib, for heart disease, for other things, we are more careful with them, because sometimes that you can have delayed hemorrhage, and they might need observation, or they might need repeat CAT scan. Um, and it's very important to have to make sure somebody is watching the patient. If it's a kid, make sure the parents are going to watch the kid. If an elderly, uh, a lot of elderlies live alone by themselves, and if they have mild TBI, you don't want to send them home to be on their own because somebody has to watch for any change in mental status or any additional symptoms. These are a few things that you need to keep in mind when you deal with mild TBI. Moderate TBI forms about 10% of the TBI. As I said, GCS is somewhere between 9 to 13. And here you have some evidence of brain injury. It's not just shaking of the brain. You have brain injury. And preventing secondary insult is a big deal here. Maintain the normal blood pressure, maintain the oxygenation, prevent the brain swelling, and how to manage it is by ABCDE that we will talk about briefly. Severe TBI, another 10% of TBIs. Here, GCS is lower than 8, and preventing secondary injury is even more important. The way we function in the emergency room, the way we take care of the serious pathologies is by dividing our attention into two parts: primary survey, secondary survey. Primary survey is in the first few minutes where you see the patients, you have to assess whether there's any life-threatening situation or not, whether this patient is at risk of immediate death or immediate loss of limb. So you have a few minutes to quickly go through the patient to make sure they're going to live. And then when they pass that part, then you have time to go through, do a more thorough examination, obtain history, do your tests. So divide your attention into primary and secondary insults. ABCD is part of is how we organize our uh, primary survey. So A stands for airway. The first thing to do, obviously, you have to make sure that the patient is breathing. Make sure nothing is blocking the airway. Make sure the patient is able to maintain their airway, right? If there is serious facial bone fractures, if there's a lot of bleeding in the mouth, if the tongue is swollen, the patient is not going to be able to maintain their airway, and you have to protect the airway, right? If the mouth is open, if the patient is talking, then you move on from the A to B. B is breathing. Make sure the patient has good breath sounds bilaterally. Make sure the oxygen saturation is normal. If oxygen saturation is low, you put the patient in oxygen. If they need respiratory support, you provide respiratory support. C stands for two things. C-spine. A lot of patients with head injury have C-spine injury concomitantly. So you have to secure the C-spine so the C-spine doesn't move. And then the other C is circulation, which we talked about. Circulation was about maintaining the blood perfusion, maintaining the blood pressure. Check the skin. Is the skin well perfused? Talk to the patient. If the mental status is altered, perfusion is compromised, you need to do something. Check the pulses. If the pulses are fast and thready, you need to give fluid, you need to give blood, you need to restore the perfusion, right? So that's the C. D stands for disability. Look for any signs of serious neurological dysfunction, such as check the pupils to make sure the pupils are not dilated, fixed or dilated. Make sure there's no other evidence of neurological damage. And E stands for exposure. They have to avoid hypothermia. We talked about hypothermia yesterday. That's one of the three elements of the triad that occurs in trauma patients and causes serious secondary insult. So A, B, C, D, E. Um, let's do an experiment. Ma'am, what's your name? What's your name? Can you stand up? Nice to meet you. How are you? How long have you been here? Since just a few months, brand new. Where are you from? Mississippi. Wonderful. Thank you. So all right. I did my A, B, C, D, E on this young lady. Uh, what was A? Okay. Was her airway okay? She's speaking clearly. She's able to. She's not in any immediate danger of airway loss. Breathing. She doesn't look tachypnic. She's breathing comfortably, speaking comfortably. B is intact. C. How did I measure the circulation? Okay. What else? Two things I did. So I touched her skin. The skin is warm. If the skin was cold and clammy, her perfusion was intact. So one of the things that you do in the emergency department, the first thing you do, you talk to the patient, touch their skin. It's an easy test. If the skin is cold and clammy, you're in trouble. If the skin is warm, at least in that moment, the perfusion is maintained. The other thing that I did to measure her circulation was measuring her mental status. Her mental status looks okay. She knows her name. She knows where she is. She knows how long she's been here. So the mental status is fine. That means the brain is being perfused, right? The in terms of disability, she was able to stand up. She was able to move her hands. The D part is taken care of. So doing an ABCD can be really quick, really efficient way to determine how much trouble you are in or how fast you have to act to make sure the patient survives. Good. So remember, the C in ABCD was C spine. Sometimes people get carried away when the airway is in trouble, and you want to secure the airway. You want to make sure the patient is able to breathe, and you forget that C spine could be also injured. And by moving the neck, by moving the head, you can actually cause spinal cord injury. So whatever you do for A and B, make sure somebody is holding the neck, someone is securing the neck until you get a C collar around the patient's neck. Especially if you need to intubate, during intubation, you have to have inline immobilization of the spine so people don't flex the neck too much or move the neck to the left and right. Maintaining the neck immobilization and making sure the spinal cord is intact during all these uh, interventions is extremely important. Of course, I'm not going to go through the details, too much details into intubation, but if you notice that the airway is compromised or could be compromised, if somebody has either a lot of blood in the mouth or a lot of fractures in the face, and it could compromise breathing, you have to intubate them prophylactically. Or if there's a lot of the evidence of a lot of brain injury, and you know this is going towards herniation, this is going to go towards respiratory arrest. Sometimes you do intubate the patient. The steps that we do is first we pre-oxygenate the patient, we bag them, give them a lot of oxygen, bring the oxygenation to 100% for a few minutes, and that will allow us a few minutes in case the intubation is difficult. You want to make sure there's enough oxygen to allow you a few minutes to do the intubation. Then pre-medicate. There are two types of medications we give to patients before intubation. One is sedation, either etomidate or ketamine, something to sedate the patient, and then paralyze them. You need to paralyze them in order to all the muscles in the mouth, larynx, neck to relax, so the tube can be safely passed. And you don't want to paralyze someone before sedation, right? Uh, so you have to sedate first, then paralyze them, and now you're ready to intubate, and you pass the endotracheal tube. You can suction the airway, put the tube in. When the airway is secured, that buys you a lot of time. If you take the airway issue out of the picture, that allows you to send the patients with severe brain injury to the CAT scans, to different procedures, Um, the securing airway buys you a lot of time, gives you a lot of maneuver room to pay attention to the rest of the body and not worry about the airway compromise. One of my old mentors, we have a lot of trauma in Kings County Hospital, and a lot of uh, badness happens. And one of my old mentors says, if a patient uses the F word 3 times, they should they need to be intubated. We don't follow that rule, but so for breathing, the objectives as we talked, PA arterial pressure should be more than 60. O2 saturation should be more than 98 or even more than 95, and end-tidal CO2 should be around 35. We talked about circulation, make sure the blood pressure is adequately maintained, and if you notice that the blood pressure is low or the patient is altered or the skin is cold and clammy, uh, then you need to restore the blood pressure by uh, giving IV fluids or even blood. As we said yesterday, in you cannot bleed a lot in the skull because it's a limited space. If you have a scalp laceration, you can bleed a lot, and for those patients, you need to give blood and move from IV fluids quickly to blood because IV fluid obviously doesn't have any ability to oxygenate. So you need to give blood. So if there is evidence of blood loss from a scalp laceration, or sometimes these are polytrauma patients, right? Not only they have head trauma, but they could have intra-abdominal trauma, they could have open fractures, they could be bleeding from other parts. So in trauma, when there is an evidence of blood loss, you don't want to give too much fluids, but you want to move to blood transfusion as soon as possible. And then the disability, you look for evidence of neurological damage based on your physical findings. You can do, you look for pupils. The scary finding that we have in patients with severe traumatic brain injury is fixed dilated pupils, and especially unilateral one. That usually means that the brain has been has herniated, and it's a very ominous sign. But if your pupils are reactive um, uh, to light and they're not dilated, that's a good sign. And exposure, we talked about it yesterday, avoid hypo or hyperthermia. Sometimes after brain injury, because of the inflammation that happens in the brain, the temperature can goes up. People could be febrile, but that's not from an infection. It's from the inflammation in the brain. And remember, when you have inflammation, when you have fever, the metabolism of the brain increases. When the metabolism increases, the brain needs more oxygen, needs more nutrition, and you already have a brain that might be hypoxic, might be hypoperfused, and you don't want the fever. That fever can do some secondary damage to the brain. So you have to maintain the temperature normal. And hypothermia can promote acidosis and can promote coagulopathy. So we don't want that either. We have to maintain the patient normothermic. So after the primary survey, when we determine that the patient is not any immediate danger to die, then we can go back and now do a thorough examination, head to toe, look for other signs of injuries, look for um, do a thorough neurological examination, maybe get our CAT scan, maybe check our pulse again, pulse oxygen, check the oxygen, check the temperature, check the CO2 level, look for other signs of injuries. Do you know what this is called? I hear something back. Raccoon eyes. What does it mean? skull base fracture. Skull base fracture. So when you have a skull base fracture, usually the skull base is a is a bad sign. That means that there's most likely brain injury. So you have two signs that you look for in your secondary survey, one for raccoon eye and hemotympano, either blood behind the tympanic membrane or bleeding from the ear. Both of these means the brain skull base is broken, and that's usually associated with some serious brain injury. There are these are the signs of secondary insult to the brain. Someone who initially wasn't altered, now the consciousness is changing. They are becoming altered. Their respiration pattern changes. They become agitated or restless. Remember, agitation is always a bad sign. It means the brain is either hypoxic or hypoperfused. We have to take agitation and restlessness very seriously. Severe headache, focal signs, nausea, vomiting. Nausea and vomiting frequently happens even in mild traumatic brain injury, maybe once or twice. But what is more important or bad sign when someone has persistent vomiting more than once or twice, then that's an evidence of increased intracranial pressure. Hyperthermia, we just talked about it. Hyperthermia is bad. Seizure is probably one of the worst things that can happen to someone with brain injury because that hyperexcitability in the brain that is already damaged causes the increased metabolism in the brain. The brain is being the signals being fired. They cause um, extreme excitation of the brain cells. They need more. Brain needs more oxygen, more blood, more nutrition during seizures, and the blood and the brain is already deprived of those three because of the brain injury. So seizure is really bad. However, um, there's some evidence that maybe if someone has severe brain injury, giving them anticonvulsants might help. The evidence is kind of weak. Maybe yes, maybe no. Some people do it, some people don't do it. But in general, when you have a severe TBI, not much in mild or moderate, but in severe TBI, we generally tend to give people anticonvulsant to prevent the seizures that would add injury to the insult. The other signs of secondary injuries are bradycardia, tachypnea, hypertension, dilated pupil. So your job when with TBI, you do the you do the primary survey, you do the secondary survey, but your job is not done because as the brain swelling increases, as the size of hematoma increases, things can change. So you just have to always keep an eye on them. Um, and it's in the emergency department environment, sometimes it is hard because you have this patient that you're taking care of now. There's a cardiac arrest, and you move to the cardiac arrest, and then there's a gunshot wound. You move to the gunshot wound. You have to keep an eye on all of these patients at the same time, particularly the TBI patients, because things can change pretty quickly and you have to identify those signs immediately. This is usually a bad sign. It's called Cushing triad, a combination of widening pulse pressure when the difference between systolic and diastolic pressure is very wide, bradycardia and irregular respirations. That usually means the brain is in trouble, the sign of herniation, sign of severe brain injury, and usually a very ominous sign. In certain cases, when you realize that the ICP has increased, you may want to do ICP monitoring. This is where a neurosurgeon inserts a catheter inside the brain and they measure the ICP. And then if ICP goes up, then you have to take measures to bring the ICP down. And this is so neurosurgery comes into picture when you need to measure the ICP. And then sometimes if the hematoma is growing, so you had someone who initially wasn't altered, has an epidural hematoma, and now the patient is altered. Now you're having some signs of secondary insults, some neurological finding. That means this hematoma is growing and you need to intervene, and they can go and aspirate, evacuate the blood, evacuate the clot, and relieve the pressure from the brain. One of the ways to reduce the intracranial pressure is to increase the osmotic pressure inside the vessels. So when you give someone hypertonic saline or you give them mannitol, you increase the osmotic pressure inside the vessel. What does that do is kind of sucks the fluid from this extravascular tissue inside the vessels. When you get that fluid into the vessels from the tissue, it reduces the swelling and it buys you some time. It the sometimes when this ICP is high, um, giving this is very important. It there have been tons of studies comparing mannitol to hypertonic saline, and the jury is still out which one is better. Whatever you have, you can use. And prevent seizures, as we talked about sometimes. There were some studies in the past that to give a steroids, but there's no evidence that the steroid, because the idea was that brain inflammation after injury, you have inflammation. Maybe if you give some anti-inflammatory like steroids, that's going to reduce the inflammation. Sometimes something that is biologically plausible doesn't really pan out when it comes to patients' outcome. So we don't give any steroids anymore. But good evidence that preventing seizure is good. Sometimes you need to sedate the patient and paralyze them in order to reduce the agitation, reduce the ICP, because every twitching, every movement, every contraction can cause increased ICP, and sometimes paralysis and sedation helps. The other thing that sometimes we need to do is propofol. Propofol um, causes kind of asystole of imagine asystole of the brain. Propofol suppresses all the brain activities. And by doing that, you allow the brain to rest, you decrease the metabolic needs of the brain, and sometimes it's necessary, that is necessary to bring the ICP down. The simple thing that you can do is to elevate the bed um, 15 to 30 degrees to reduce ICP. It's a good trick that you can do, but don't forget that you still have to watch the C-spine unless you already have your C-spine CT and ruled out any C-spine injuries. And unfortunately, sometimes after severe traumatic brain injury, you have brain death, and that's when the GCS is 3 and all the reflexes are, the brainstem reflexes are gone. There are several tests that they do. It's not an easy thing to determine, but usually neurologists have a bunch of different tests that they determine, okay, the patient is brain dead, there's no brain activity, and you can withdraw uh, all the life-saving efforts. So let's go. Let's just this is the end. Before we talk about before I answer questions, I just want to go through this because I know there was a lot said here, a lot of information. But let's say you have someone who is suspected of head trauma, and you are the doctor who's going to take care of this patient. How do we go through quickly managing this patient? Remember your ABCD primary survey, right? Make sure airway is open. If there is a lot of blood in the mouth, a lot of blood in the nose, make sure you suction the airway from blood, from secretions. Make sure the airway is open. Make sure the tongue is not blocking the airway. Make sure there's nothing else that could compromise the airway. Then you move to B, check the breathing, check the oxygen saturation, make sure the air movement is adequate. Sometimes in polytrauma, you have pneumothorax, tension pneumothorax, hemothorax, so you have to make sure the breathing is okay. Then C spine, maintain the C spine, immobilize the C spine, make sure nobody moves the patient, especially for trauma patients, we roll them over to look in their back, touch everywhere, touch the spine, look for other signs of injuries. Sometimes we have to control the airway with intubation. During all those efforts, make sure somebody is holding the neck and moves with the neck, moves with maintains, immobilizes the neck when we move. The C is circulation. Touch the patient, house the skin, check the pulses, check the blood pressure. Make sure you restore the perfusion, maintain the blood pressure before you move on to anything else. Then you do check for immediate signs of disability, raccoon eyes, check the pupils, check for hemotympanum. And when you pass this uh, primary survey, then you have time to do more examination, and then by then you will have more people to determine whether you need a neurosurgeon, you need a trauma surgeon or not. But your job is ABCDE, make sure the patient is going to live, and then determine after doing your secondary survey, you can determine whether you need CAT scan or not, whether you need x-rays, whether you need chest tubes or any other thing. The immediate part, ABCDE, is the key. All right, questions? Yes, sir. It's not, the question is why skull-base fracture a sign of disability. It's not. It's just means that breaking the skull base requires a lot of force. So when you have a skull base fracture, that means the force that impacted the brain is significant. So you should expect severe injury to the brain. Yes, ma'am. That's a very good question. The question is, if someone is intoxicated or you are suspecting that they're intoxicated, how do you um, evaluate their mental status, or can you blame the mental status change to intoxication and not brain injury? Unfortunately, this is a very, very common issue because people who are drunk are more likely to get involved into altercations or drive and get into motor vehicle accidents or motorcycle crashes and everything. So it's a very, very common finding. uh, it's always safe to consider the worst. You cannot uh, simply say the patient is drunk, then the altered mental status from his drunkenness. You consider the worst. You take that as a sign of brain injury until proven otherwise. We've had uh, we've had many cases, at least in my career, that I have seen that someone was drunk and was altered. And we have a whole section of our emergency department that is dedicated to drunks. We just put them in there. Most of the time, these are our regulars. They are there every day. They are released from the hospital. They go get drunk, and then they fall. Somebody calls EMS. They come back, and then we park them at some corner and say, "Oh, is Mr. James or Mr. X that is just drunk again." And then every few months, one of those people have epidural hematoma, a skull fracture, because uh, when they get drunk, you don't know if they were hit by a car, Maybe they fell downstairs. Maybe something else happened to them. It's assuming that they're drunk again is could be detrimental. So it's always better to um, consider the worst. And those are the people to use F words more than others, and they get intubated more often. No, but we do that actually not uncommonly. If someone is very belligerent, whether they're too drunk or too aggressive, they're on drugs, cocaine users, they are more aggressive. Heroin users are usually chill and calm, but people who took stimulants, they can be really aggressive and agitated. And for their safety and for the staff safety, we sometimes sedate them, paralyze them, intubate them, then we do all the workup, and then when everything's done, if everything is negative, then we extubate them. So they can, if someone is too drunk or too belligerent, too aggressive, they buy themselves intubation for the safety of their safety and our safety. And then worst case scenario, they can get extubated in a few days. So there is some logic to that F word recommendation. Anything else? Okay. Thank you very much. Of course.